Hello, good evening, everyone. I welcome you all to the neurosurgical webinar with our two esteemed neurosurgeons, Dr. Koka Gogichashvili and Dr. Tornike Kldiashvili. This neurosurgical webinar is presented by IASSS. It is the International Association of Student Surgical Society in collaboration with GIMSOC, which is Georgian International Medical Student Society. We will be beginning with Dr. Koka. Dr. Koka is one of the esteemed neurosurgeons in Tbilisi. He is practicing currently at Caucasus International EVEX Clinics. He is also one of our mentors from New Vision University. Please welcome Dr. Koka. We also have Dr. Tornike. He is also one of the esteemed neurosurgeons in Tbilisi, Georgia. He is also at Caucasus International EVEX Clinics. And please welcome these neurosurgeons. Dr. Koka.
Hello, everyone. Hello, every participant. It's a great pleasure for us. I'm talking by name of myself and my friend Tornike Kldiashvili. We are together and we're so happy to join this webinar, and we're happy to share our experience in the field of endovascular and spine surgical methods in neurosurgery. Thanks, Rajika, the excellent representatives of our country in this excellent team with this group. Thanks this opportunity to be here today and to share our knowledge and experience in this field. Thanks. We are here and we are waiting our QA to represent our own cases today's webinar.
Thank you so much, Dr. Koka. You can start presenting. Dr. Koka is going to talk about endovascular treatments today with us. And I would like to invite you to please start presenting your screen, Dr. Koka.
Yes, I will share my screen at first. And as you know, our main topic is to talk about endovascular treatment of acute vascular pathologies of the brain. We will meet ischemic and hemorrhagic strokes, and we will cover the main fields of endovascular treatments in this topics. In those cases, when we have acute pathologies of the brain vessels. Here we will cover the two topics, ischemic and hemorrhagic strokes, and we will discuss about nowadays treatment methods both in ischemic and hemorrhagic strokes, and we will mainly focus to endovascular treatment as the less invasive and less traumatic treatment options in neurosurgery. As you know, ischemic stroke is the 87% of whole strokes, and the mainly it's represented as a occlusion of the main vessels of the brain, which mainly gives them blood flowing to the main regions of the brain, and approximately 15% of whole stroke cases comes to the subarachnoid and hemorrhagic stroke, which is caused by rupture of aneurysm. And today we will cover endovascular treatment of both the subarachnoid and ischemic strokes. The stroke means the reduced blood flowing to the certain areas of the brain caused by occlusion of the blood vessels, which mainly gives the blood to the main regions of the brain. Mostly it's caused by occlusion of the middle cerebral artery or internal cerebral artery or basilar artery as an anterior pool and posterior pool of blood supply. It's the caused by blockage of blood vessels that reduces the blood flow to the affected area of the brain, and it leads to ischemia of the surrounding tissue, and eventually death of the brain cells that are affected within a matter of minutes. Stroke is the 5th leading cause of death in the United States of America, and it kills 128,000 people per year. As you saw, this is the leading cause of death in our population, and it requires our first aid and urgent treatment. And today we are going to talk about this kind of treatment. You know that occlusion of the blood vessel. So I will try to turn off this video here on the table. Ischemic, acute ischemic stroke is the cause of occlusion of the large vessels as a middle cerebral artery, internal carotid artery, or basilar artery. And we have now two options of treatment as a conservative and surgical methods. As a conservative, we are using the medicine which breaks down the clots in the vessels, and we are using tissue plasminogen activator, and we are calling this procedure as a thrombolysis. It means we are using the agents which breaks down the clots by using activation of the plasminogen, which helps to decrease the conglomerates in the vessels of the brain, and intravenous thrombolysis, we are using Alteplase or Arctelise, which is the drug which helps us to break down the clots in the vessels. And mechanical thrombectomy is the way when we are inserting the catheter, so in the main artery of the where that clot is produced, and we are inserting the catheters, and we are trying to retract and remove the clots from the vessels. And according to devices, what we're using, we have aspiration or retraction techniques, or both of them. And we have the Solumbra method when we're using the thrombus retraction with thrombus aspiration. This is the combination of aspiration and retraction. Our main aim is to revascularize the vessels after the clots. So our aim is to break down the clots in the vessels. And in some cases, we are using thrombolysis. In other cases, we are using thrombectomy or together as a combination therapy. And according to newest guidelines, we have the much better outcome if we are using thrombolysis and thrombectomy together as separate. But of course, every treatment method has its indications and contraindications. And thrombolysis, we have time limitation. We are not performing thrombolysis if stroke symptoms, the window is more than 4.5 hours. So when stroke symptoms started for 4.5 hours than before. And we have the contraindications for thrombectomy as well. It's 6 hours. As for intravenous TPA, tissue plasminogen activator is the clot busting drug used in the stroke patients, and patients must be within the first 4.5 hours from symptom onset. And also there is other contraindications in which cases we are not using this drug. And those contraindications are the age. First of all, we are not performing any thrombolysis and thrombectomy if the patient's age is less than 18. If patient has any diagnosed vascular pathologies, intracranial pathologies as an aneurysm or fistulas or AVMs, or tumors as well. If patients has any coagulopathies, if platelet levels are 80,000, if there's any coagulopathies and INR level is more than 1.7, if patients passed any surgeries within 4 weeks, if it was any lumbar puncture or any intervention before 4 years, if there was any bleedings during 4 months, 4 weeks, 1 month, and if there's any active bleedings from mouth or hemorrhoidal veins or gastrointestinal tract. Those are contraindications, or and also uncontrolled blood pressure or uncontrolled glucose, in which cases we are not performing thrombolysis. And as for mechanical thrombectomy, every contraindications, what were in medical management, plus idiosyncrasia with iode or idiosyncrasia or any allergy to the contrast solutions, what we were using during the procedure, and also high creatinine levels, moderate contraindications for mechanical thrombectomy. Mechanical thrombectomy is the procedure when we are using stent retriever, which is placed in an occluded vessels and in the groin. And for this mechanical thrombectomy, we have we are so limited in time. We have 6 hours to perform mechanical thrombectomy to revascularize the vessels. Of course, we can perform mechanical thrombectomy more than 6 hours, but the outcome will be less than if we are performing the mechanical thrombectomy within 6 hours. If the patient fails intravenous TPA or is ineligible for intravenous TPA, they may be eligible for mechanical thrombectomy. We have to know here we have the dependencies according to time and clinical outcomes. Then it shows that as early we are performing mechanical thrombectomy or thrombolysis, as better outcome we have. So time is brain, and is early we are starting treatment of ischemic stroke, we have much better outcome. Those are endovascular treatment indications. It should be, the patient should be more than 18, NIHSS score should be less than, more than 6. NIHSS is the specific scale system which uses it to assess the patient's neurological status after the stroke. Aspect assess the patient's computed tomography pictures, and it should be more than 6. And treatment can be initiated within 6 hours of symptom onset. Intravenous TPA should be performed in the first 4.5 hours of onset, and endovascular treatment generally within 6 hours of onset. NIHSS should be more than 6, and CTA on the CT. In the native computed tomography, there is no core of the ischemic stroke, and CTA shows occlusion of the major arteries of the brain. It might be it should be LVO, so it means a large vessel occlusion. Internal carotid artery or MCA's M1 or M2 segmented basilar artery should be occluded if we are going to perform any thrombectomy in those patients. This is the aspect scale which demonstrates the MCA supplied zones, and at starting we have 10 marks, and if we want to give any more scores to the patient's computed tomography, we're taking this 10 and minusing as many cores as it's shown on the CT. So we have the computed tomography, we have hemispheres and MCAs or supplied zones. If you will find one course of the one ischemic region, lacunar infarction of MCA's supplied zone, we are taking this 10, what we had at starting, minus 1, and it is 10. Now, if we have 2, we have to take this 10 minus 2, and it's 8. Aspect 6 and more is indicated to perform mechanical thrombectomy. I am, yes. Now, we can perform endovascular treatment with stent retrievers or aspiration system or Solumbra method, which is a combination with stent retrievers and aspiration together. This is the evaluation of the embolectomy devices. It was at first, and then it was now much more advanced. This is the intraarterial embolectomy devices, what was at first, and then developing of those devices. And nowadays we're using stent retrievers, which looks like this. This is where inserting the stent retrievers in the vessels where clot is stuck, and we are retracting it to revascularize the vessel. Now we'll introduce the one case from our own practice, where it was a 34-year-old patient which was admitted to hospital at 13 and 25. Manifesting symptoms was left hemiparesis and motor aphasia and decreased level of consciousness. Patient was left-handed, that's why his right-sided MCS occlusion causes left-sided weakness and motor aphasia. Patient's symptoms were started 1 hour before of symptom of the emergency. Past medical history was that patient had atrial fibrillation and patient was treated by warfarin. We performed the computed tomography with angio, and it showed the right middle cerebral arteries occlusion. We have native computed tomography here, which shows the hyperdensis of the middle cerebral artery here on the right side of the temporal lobe. This is the occlusion of middle cerebral artery. We measured the laboratory findings, of course. The NR was less than 1.7, glucose was normal, platelet level was normal, and creatinine was normal too. Now, it was considered as a candidate for mechanical thrombectomy, and patient was transferred to operative room where DSA was performed. Digital substructural angiography showed the occlusion of middle cerebral artery here and M1 segment. This is an internal carotid artery here. This is ACA, anterior communicating artery, and middle cerebral artery. We have middle cerebral arteries occlusion here. That's why there's no blood flowing distally after this clot. So we have no blood flowing in this region. We decided to perform a mechanical thrombectomy. We use those devices. I'm not sure it will be interesting for you. So we removed the white blood clots here. White means that it's organized blood clots with calcifications and with thrombosis. It was removed from the patient's right middle cerebral artery, and normal blood flow was achieved again. As you remember, it was blood clots here in this point at starting, but after the recanalization, after the removal of this clot, the normal blood flowing was achieved, and middle cerebral arteries branched are contrasted after this. Okay, there's blood flowing in middle cerebral arteries distal branches. Now, this is post-operative computed tomography, which shows no ischemic course here. It's normal because this time in which time middle cerebral artery was occluded was not enough to cause any ischemia of the brain, because we performed mechanical thrombectomy so soon and we revascularized the vessels. By showing this case, I wanted to show you and share why life-threatening important is to early treat the patients after ischemic stroke. As early we are starting our thrombolysis or thrombectomy, as good results we have. We removed and revascularized the middle cerebral artery, and afterward we had no ischemic stroke in the computed tomography. So this is the nowadays and the modern technique of surgical treatment of acute ischemic stroke. Once we have the occlusion of cerebral artery, our aim is to revascularize by using medical options such as tissue plasminogen activator, or by using stent retrievers, aspiration devices under the angiography. And this is the endovascular treatment of acute vascular pathologies. And also we have the we have subarachnoid hemorrhage, which is mainly due to rupture of aneurysm after the trauma. You know that trauma is the leading cause of subarachnoid hemorrhage. And secondary, we have rupturing of Barrett's aneurysm, which is another leading cause of subarachnoid hemorrhage. Ruptured intracranial aneurysm is a urgent medical condition which requires to prompt diagnosis very soon, and also treatment to prevent severe brain damage and to prevent rebleeding, re-rupture. And endovascular embolization with coils is the first line treatment of ruptured aneurysm and can also be used to prevent re-rupture and rebleeding. And also risk of the complications during coil treatment is very low, making it safe and effective methods for preventing short and long-term hemorrhage. And this is the way how we are occluding the aneurysm dome to prevent the blood flowing to the aneurysm dome to avoid re-rupture and rebleeding. Subarachnoid hemorrhage due to intercranial aneurysm rupture requires urgent multidisciplinary treatment by neuroradiologists, neurosurgeons, and neurologists. It has an very high incidence, approximately 10 cases per 100,000 people. This disease is more common in population of working age in 6 decades. Timely occlusion of ruptured aneurysm is necessary to avoid re-rupture and rebleeding with a mortality rate approximately 40% within 30 days of diseases. As you saw, subarachnoid hemorrhage is characterized by high mortality rates. Endovascular treatments, mainly coiling, is used in the acute period with technological advances such as 3D angiography and neuronavigation, improving the effectiveness. Except coiling, we have the central systems known as flow diverters, which redirect the blood flowing from aneurysm and eliminate the need for coils occlusion, but require long-term dual antiplatelet therapy after the treatment. Ruptured untreated aneurysms have a high risk of bleeding. Recurrent bleeding typically occurs within a few days of the first bleeding with a very high mortality and morbidity rate. Timely removal of aneurysm from the blood circulation via clipping or coiling is crucial to prevent recurrent bleeding. Our main aim is to close the aneurysm by using clipping or coiling, and I will show you what those techniques are. The aim is to avoid blood entering to the aneurysm. This is the aneurysm here. If you are inserting the coils inside the aneurysm, it means that another option. This is the clip. We are clipping the neck of aneurysm to avoid blood entering this dome. And also we have the another technique, which is coiling, when we are going here by catheters and we are inserting the coils inside. This is another way of treatment of this vascular pathologies. And endovascular treatment is the first line treatment for large group of intracranial aneurysm. This is several examples of endovascular coiling of posterior and inferior cerebral artery. It was before the coiling. It is the vertebral artery here, and from vertebral we have pica, right? Posterior inferior cerebral artery. This is the artery which gives the blood to posterior inferior part of cerebellum, and we had the aneurysm on the the junction points of basilar artery and pica, and we just inserted the coils in the dome of the aneurysm represented here. And in second picture of angio, we can see there's no blood entering there because the place of the aneurysm, the dome of the aneurysm, is occluded by coils. Here is the endovascular coiling of the internal carotid artery aneurysm, which had wide neck, and we performed the coiling by assisting of balloons, because once the aneurysm has wide neck, it's high risk to have the dislocation of coils, and those dislocated coils are occluded the distal parts of the vessels. So I will show you graphically how it looks. This is the wide neck aneurysm, and wide neck means when diameter of the neck is more than half of the whole diameter of aneurysm. For example, if it's 8 mm, the diameter of aneurysm is 8 mm. Wide neck aneurysm is considered if neck size is more than 4.4 mm. Now, in wide neck aneurysm, if we are just using coils, it's high risk to dislocate, and this dislocated coils occludes the parent arteries distal segments. To avoid this complication, we are using balloons. We are inflating balloons here. And balance now occludes the outrance of those coils from aneurysm to vessels, and there's occluded vessels in the aneurysm. And this is the one of our examples when we had internal carotid arteries aneurysm with a wide neck, and we performed the vascular coiling with balloon assistance. Here it is pre-operative, this is intraoperative, and here we can see post-operative picture of internal carotid artery, internal carotid arteries aneurysm. There's no even visible aneurysm here in this view. We have flow diverters, which are stent systems, which redirects the blood flowing from aneurysm, and it eliminates the need of coil occlusion. But the side effects of this aneurysm that flow diverters requires dual antibilateral therapies, and they are effective for bifurcations and wide neck aneurysm, and their long-term effects have not been studied yet. Yeah, we were talking about flow diverters, which are stent systems which redirects the blood flowing from aneurysm to artery, but the side effects are that it requires dual antibilateral therapies, and the long-term effects have not been studied because it's in the new techniques of endovascular treatment of aneurysm. We have two main complications of endovascular treatment during acute subarachnoid hemorrhage. Those are thromboembolic complications and vascular spasm. But it's the complications of a subarachnoid hemorrhage. We're not saying that this is the complications of endovascular treatment. It is the complication of subarachnoid itself, because subarachnoid hemorrhage main complications is vasospasm and hyponatremia or rupture, lip bleeding, or hydrocephalus. And one of the most important complication is vasospasm, when vessels of the brain are starting to constrict, and you know that constricted vessels means decreased oxygenation of the brain tissues, and also increasing intracranial pressure high, and anticoagulation and anti-aggregate therapy are used to manage thromboembolic complications in those cases. And we are using calcium channel blockers as a nimodipine, which is which use it to avoid vasospasm, to prevent or to treat the vasospasm. It blocks the calcium entrance to the vessels, and it delays the vessels. Therefore, it increases the oxygenation of the blood vessels. And also heparin, which we use it in the intervention to avoid intraoperative and postoperative occlusion of blood vessels. To conclude our meeting, diagnosis and treatment of ruptured aneurysm is urgent, and it requires urgent surgery. It might be endovascular or open surgical, so clipping or coiling. But it should be performed as early as possible to avoid high risk of re-rupture, rebleeding, because re-ruptured and rebleeded aneurysms are characterized by high rate of mortality and morbidity. Operative interventions should be performed quickly to prevent this re-rupture and rebleeding, and then the recommended time to close the aneurysm is early window. This is 72 hours, so 3 days. But the outcomes are much better if you're performing your coiling or clipping in first 24 hours. Endovascular coiling is a first line treatment in ruptured aneurysm. If there's any indications for endovascular treatments, if aneurysm size or location or angioarchitecture or size of the aneurysm neck are indicated for endovascular treatment. And this technique involves occlusion by coils with or without balloon assistances or flow diverters. And aneurysms with coils have relatively high rates of recanalization, and further observation and possible endovascular treatments are recommended because those techniques are new, and it requires to follow the results after the treatment. It was the main topic what I wanted to share today. It is the endovascular. It means less invasive and less traumatic approaches to the vascular pathologies, which is performed as a treatment option in acute vascular pathologies, both in hemorrhagic or ischemic strokes. In ischemic strokes, we discussed about mechanical thrombectomy cases with aspiration or retraction, and endovascular coiling or flow diverting in case of hemorrhagic stroke due to rupturing of aneurysms. I will be pretty happy to listen your cases if you have any questions about this topic. I'm ready to answer.
Thank you so much, Dr. Koka. It was very interesting to learn about these treatments and also the case discussion that we did. Both the presentations were quite amazing and quite interesting. I will go through the chat, and some students have sent to the host directly and some have sent in the public chat. So I will be reading out the questions for you.
Okay.
There is one question. It asks, what are the benefits of endovascular therapy in patient perspective, apart from like the scientific perspective, if we see like how it is more beneficial to the patients?
Yeah, of course, if we will roughly say, so endovascular technique requires just one puncture in a femoral artery or a radial artery. And if we will roughly see this technique, of course, it will be less traumatic and less invasive compared to craniotomy and removing the bone flaps from the skull. Of course, it will be much easier for the patients, and of course for the doctors as well. It's much comfortable for them, for each side of them. But sometimes we need to avoid this much traumatization due to open surgeries, but aneurysm structure or angiostructure or physioanatomy or size of the neck are not indications for endovascular treatments, and we're going to perform open surgery. Also, if we have any cerebral or intraventricular hemorrhage which requires decompression craniotomy, we are going to perform an open surgery because endovascular treatment will not enough. So we have several indications and contraindications in both cases for endovascular and open surgical. But if we will sum up those, if we will conclude those techniques, of course, if it's available to perform endovascular treatment, it's much more comfortable, much less traumatic, and much less invasive compared to open surgical methods.
Thank you, Dr. Koka. There is one more question.
Yeah.
It is asking what complications may occur if we provide the TPA therapy after 3 hours, because it is like before 3 hours we have to give therapy.
The main complications after thrombolysis is hemorrhagic transformation of the ischemic stroke. This is when we are calling this condition reddishness. It means when we have the acute ischemic stroke, so ischemia in the brain, and after the treatment of thrombolysis or thrombectomy, this ischemic regions are hemorrhagic. This is when we have bleeding in the brain because of the thinning of the blood, and once blood is thinner than before, it's high risk to passes the intraluminary to transluminary, and we have the blood accumulation outside the vessels. This is the transformation of ischemic stroke to hemorrhagic stroke. So, as a main complications of thrombolysis, and also in case of thrombectomy, this is the hemorrhagic transformation of the stroke. Like it is in myocardial infarctions, you know that when we are stenting, we have the hypoperfusion syndrome. We have in the brain as well. We have hyperperfusion syndrome in the brain, which is mainly, not in many cases, but some cases, we have the transformation of ischemic stroke to hemorrhagic one, and we have the bleeding in the brain because of thinning of the blood.
Okay, thank you, doctor, for the detailed information. There is one more question, and then we can have a short break and we can begin. There is one last question. It says, what is the prognosis after intra-arterial embolectomy?
Prognoses are pretty good, and my presentation was to talk about this topic as well. Of course, this is the best method and the good outcome treatment if you are performing intra-arterial thrombectomy. It means a vessel is occluded by clots, and you are directly removing the clots, and you are revascularizing the vessels again. So of course the outcomes are best, but thrombectomy has its indications, its time limitation, its contraindications, and if you are following those indications and you are in time window when it should be performed, of course outcomes are best, and if of course you are saving the life, which is definitely will be characterized by high mortality and high morbidity. Outcomes after intra-arterial thrombectomy are good, and nowadays we are happy that we have this chance to revascularize the occluded vessels.
Thank you so much, Dr. Koka, for the amazing answers. Now we will be having Dr. Tornike Kldiashvili with us. He's one of the esteemed neurosurgeon in Tbilisi. He has had successful surgeries with intracranial aneurysm resolutions, and he will be discussing with us today the odontoid fractures at the vertebral level. Please welcome Dr. Tornike.
Greetings. Thank you for this opportunity. Today we will speak about C2 odontoid fracture, about indication for posterior and anterior fixation in C2 fracture, and our experience our clinics in this surgery type. Let's start about anatomy of C1 and the C2 vertebrae. What's more important in this case is fractures. Here we see of C1 vertebra. And what's important here, what we must know about when we started about surgery in this fracture, it's in C1, it's transfer ligamentum. We must know it's damaged or not to decide which approach we must use, anterior fixation or posterior fixation. If we have damage of transverse ligamentum, we decide to use posterior fixation. And also we must know about lateral mass, where we put a screw when we do posterior fixation, like we see in the front, it's here. And about C2 vertebra, it's what's most important, it's lateral view. Here we see odontoid, and it's lateral and posterior view. Next one is posterior view. Here we see of what's most important, it's vertebral artery. What can be damaged when we do posterior fixation? It must be allowed, try to not damage. And here we see entry points when we do. Here is lateral entry points for lateral mass of C1, where we put screw here and here, left side, right side. And also we see entry points of C2, where we put screw also. Next one, it's indicated of scalpel granular junction, lines and angles. It's what's important we decide it's we have or not instability in this fracture. Let's not speak about this because it's take a long time. If someone interested, we can make screen and decide to read. Let's start about epidemiology. C2 fracture is most common fracture of the axis. Account for 10 and 50% of all cervical fractures. And also it's most common in elderly patients. We have this fracture. Demography is more adult than younger patients. In other most common of simple falls, it can be simple falls and delight, which mean increase the mobility and mortality compared to younger patients with this injury. In younger patients, a result of blunt trauma, motor vehicle accident, follow from high to make a hyperflexion or hyperflexion or hyperextension. And in children, rare this fracture and almost occur a site of vascular synochondrosis. Mechanism of injury is most common is hyperflexion. Here we see of left side, and not so common hyperextension. Here we see in right side. Okay, clinical presentation of these fractures, most common is only neck pain. They're very rare to another presentation. It can be dysphagia, maybe present with if we have a large retrofoveal hematoma. Neurological deficit is very rare in these cases because we have a large cross-section area in this level. In radiology, we can take classic X-ray, CT scan, and MRI. Here in X-ray, we see odontoid fracture here. on CT scan is coronal view and lateral view. Is lateral view, sagittal view, sorry, we hear their fracture for odontoid, and in coronal view we see here, and no, also MRI, and also in MRI we see damage of spinal cord. Classification of odontoid fracture is gold standard is Anderson classification. Is most common. We use this in our days is gold standard to use to make operation or to don't make operation. To what approach we use. There are three types of fracture. First type is oblique avulsed fracture of tip of odontoid. Here we see in coronal view, and we see all the lateral view. Type 2 fracture shows the base of odontoid, base of dents, here, fracture here, and also here in lateral view. And type of 3 fracture shows the body of C2. This classification help us to decide what to do surgery and to make conservative treatment. Also, there are Roy Camille classification that with this classification, we know which side will be displacement of odontoid. It will be anterior, which will be posterior, and these types, it's used not so common. It's not make our decide to the surgery. It's just to make do for us more information what we can do. But we also use this one. Is first type, and when we have oblique linear fracture, which its then slopes forward, which dense displacement will be anterior. And type 2, when we have linear fracture, which is sloped backwards, and there we know the displacement will be posterior, dense will be posterior. And also we have a type 3 horizontal fracture. In this fracture, in this type of fracture, it can be displaced like anterior, like posterior. Type 1 fracture, it's very rare. I have saw only one time this fracture, this type of fracture, and it's help immobilization help business in 12 weeks, color of hollow immobilization, and fusion near 100%. There are no problem of this treatment, and also we can do nothing, even not use a color of hollow. This will heal himself. It's type of cervical immobilization. This is hollow immobilization. We see how it looks. There, this is color immobilization. It's how it's used on people. Let's speak about third type of treatment, and we will be speak about second type here. It's here 90%. It will be here with immobilization. Hollow near is 100 immobilizations. It's always helpful. Rigid collar helps in 70% in these cases. But there are patient factors. It's like age, medical contribution, etc. And shallow type 3, we can decide like type 2 if we have more than 5 millimeter distraction. Then we decide to consider surgery. Also, in type 2 fracture, there are treatment options. First one is immobilization, classical immobilization, like hollow, rigid collar, but it's not helpful in these cases. And we have surgical treatments. There are two types: anterior fixation and posterior fixation. In anterior fixation, we have, if we have transverse ligament, about to speak earlier, intact, it's no damage, we decide to use screw fixation, anterior screw fixation, odontoid fixation, with one screw only. And if we have damage transverse in ligaments, then we have a posterior approach, and there are a couple types what we can use. It's one C1 fracture always used in put screw in lateral mass, and C2 there was some combination what we can use. It's pars intra-articular screw fixation, pedicular screw fixation, translaminar fixation, transarticular fixation. Also, we have old style of surgery. It's like a Halifax clamp fixation and wiring. We don't use it our times now, but it's classic. It's was using, and it was helpful in other times. Surgical indication to treatment type 2 fracture. It's important. It's a displacement more than 5 millimeter. Is angulation of the fracture more than 10 degrees. Also, fracture communication is communication and communication. And also delayed treatment, what can be in elder patient. They can have trauma 1 month ago, 2 months ago, 1 year ago, but in control CT scans or MRI scan, we see there still fracture. And then we must decide to surgery. And also age. Well, in nowadays, in more than 50 years, we decide to use surgical treatment. It's have more benefits than conservative treatment. Okay, let's speak about odontoid screw fixation. First one about surgical time, patient place. The patient is placed supine of the operation table with a pen under the shoulder to induce extension. We must make maximal extension to make approach to C1 from C2 base to C2 tip of odontoid. Also, we must have bipolar fluoroscopy is used to obtain simulation anterior, posterior, and lateral views. We must have all this used to not damage the structure like a spinal cord or artery or some veins. Also ligaments and etc. Lateral view, there the lateral view of chest, neck, and cervical spine, and then odontoid show. We started from a straight trajectory from the chest, and it will give us to right trajectory from the start of C2 to the tip of odontoid. We made incision of C5, C6 level. It's a surgical technique. It shows here how we put starting put and finished screw placement. Here we see fracture and how we start. So we must start from the base and for the tip and finish to the tip of C2 fracture. It's showing in X-ray how it must shown X-ray and CT scan here. We see coronal view. This is odontoid. Here is fracture. Here is screw. We see how it started and to the starting and finishing to the tip of C2. It's a lateral view. Also here we see how it started and finished. It's good placement, how it must be done. Here in CT scan, in axial view, we see how it looks. And let's speak about a couple hour cases, what was done in our hospital. First patient is patient 63 years old with a history of fall without neurological deficit. Only pain in his neck was most common in these cases. Here we see C2. Here we see fracture. Displacement more anteriorly, and here we see screw was placement from right side, starting from the C2 basic and finish to the tip. It's a axial view where it must be central, not so central, but it's not bad. Next one, patient with major trauma. It was also, this patient was also without neurological deficit. It had in this case we have displacement, very big displacement from posterior, but here we had no damage of transverse ligaments there. That's why we decide to make anterior fixation. In this preoperative CT scan, we hear this fracture, and postoperative scan. There are no displacement. We put a screw inside the beginning. Second patient also had only neck pain without neurological deficit. Here we see fracture line. Here we have angulation without no displacement, but we here also decide to make surgery. Here we see how it's placed on sagittal side, sagittal view, and on 3D reconstruction. Let's speak about posterior fixation. Like I said earlier, it's some types of this fixation. C1 always do in lateral mass when we put a screw, and in C2 we have a couple variants. C2 fixation options include its C2 laminar screw, C2 pedicular screw, C2 pars screw. What's used most common? It's make less damage, less risk to damage like vertebral artery or spinal cord. And here on picture we see how it can be. It's yellow one, it's a laminar. Also purple one, it's a transarticular fixation. Green one, it's a transpedicular fixation, and transpars fixation. Also, we see here in the picture is odontoid anterior fixation and articular fixation. And let's speak about history. It's Halifax clamp fixation. It's using now, but not so common. It's fixation when we use Halifax system to fixation lamina of C1 and C2, and also we use autograft from pelvic. We use bone to combine this system. And also wiring. It's also history. In our days, no one uses this one, but it was common earlier, and they had good results of this fixation of this fracture. Also, we use autograft from pelvic to put between lamina of C1 and C2, and their fixation of wiring. Okay, the couple cases with posterior fixation, what we were do in our clinics. For example, it's a 73 years patient with history of fall, also without neurological deficit. This one is preoperative scan. Here also was damaged transverse ligaments, and that's why we decide to make posterior fixation. Here we see postoperative CT scan. This one is C1 lateral mass fixation screw, and this one, I don't know, is transpedicular screw, and second one it's a pars screw, C2 pars screw. Okay. Also, this very interesting patient was 50 years girl, came after a motorway vehicle accident to our clinic. She had also brain edema, traumatic edema. We made decompression, two-side decompression. Also, she had C2 fracture. First one was what was it? We made decompression, was needed for her for the surviving. After this, we made cranioplastic with own bone. Here we can see. And after surgery, after this surgery, we also made C2 posterior fixation, the lateral C1 lateral mass fixation and C2 pedicular fixation. And also patient of 78 years old, also his fall from the tree, also without any neurological deficit, only complaint was neck pain. Here we see preoperative CT scan. We see the fracture from anterior, displacement to the anterior. Also, there was damage on transverse ligament. That's why we decide to make posterior fixation. And here we see classical C1 C1 lateral mass fixation and C2 pars fixation. All these patients went home in 1 week. Only one 50 years old girl was 1 month in our clinic. What's give us to understanding this fracture is not so common. It's not so hard to understand. This fracture is difficult for the surgery, yes, but more of them have no neurological deficit. That's why we have good results after surgery or after conservative treatment. This will help, and it will be all. It will be interesting if you have some questions.
Thank you so much, Dr. Tornike, for the interesting presentation. I would like to call Aditi. She is one of the representatives. She's the event director for our collaborator society, GIMSOC, and she will be discussing the Q&A from the chat. And we also received certain questions by the students directly to the host. So we will be reading those questions as well. Thank you so much.
Yeah, you're welcome.
Good evening, everyone. I'm really thankful, and I would like to extend my gratitude on behalf of GIMSOC and on behalf of everyone at GIMSOC to Dr. Koka, to IASSS for this collaboration. I would talk more about this, but right now I would like to pose the question that the members have sent on the chat. So one of the questions, Dr. Tornike, is that, by the way, thank you so much for your lecture. That was truly intuitive. So one of the questions they asked was, which is the most common type of fixation that is used, and does it take it into consideration the type of fractures and the age of the patient?
Yeah, most common it depends of fracture type. It depends we have damage of transverse ligaments or not. We have instability or we don't have instability. Yes, most commonly we use anterior fixation. It's one screw, it's less damage for a patient, it's better for him, there less complication after surgery, like infection or wound infection or something else. And also it's easier for a surgeon to do because we have fluoroscopy, biportal fluoroscopy. We see like lateral view, we see anterior view, posterior view. But it depends what patients need. If patient need, this patient have indication for the posterior fixation, you do posterior fixation. If patients had indication for anterior fixation, you do anterior. It depends of trauma. It depends what's better for a patient. Most common we use anterior fixation, because we had types of fracture without damage of transverse ligaments.
Yes, sir. Thank you so much for the answer. The next question
One
is
more. Most
sorry.
important, what surgeon can do better? It's also important. If a surgeon can do anterior fixation better than posterior, or posterior better than anterior, he decides this one. It's also important. If he can do both, it depends what's indicated you have. But if he can do good to only one of the type of surgery, it depends on him.
Thank you so much, sir. Thank you so much for answering that question. The other question that was asked is, which odontoid fracture types are stable, and what are the goals of fracture treatment?
Stable fracture is first type, and third type it's stable fracture. In first type, it's always stable fracture when we can use only, we always use only conservative treatment like immobilization, like collar or hollow fixation. In type 3, like I said, if it's stable fracture, we see it's in CT scan or MRIs. If it's stable, we use also immobilization, not surgery. But if there displacement of fracture more than 5 millimeters, it means it's not stable fracture, and they're considered of surgery. And type 2 fracture is always unstable, and in 99% we decide to use surgery, not immobilization.
Thank you, doctor, so much for answering that question. Do we have any more questions? We have a common question for the both of you. For a lot of us, you know, people admire superstars, but for most of us attending this webinar, both of you are superstars to us. So thank you so much for the lecture. Thank you so much for attending. Thank you so much for sharing your knowledge and time. One of the questions that was asked was, I think it's more of a personal question, is that what steps should we take as medical students to become a neurosurgeon? If you could just guide us about that, give us some sort of insight on how we can achieve that goal.
It's most difficult question.
Yes. We are so under the pressure that we are someone's examples, and thanks that we take a fire in someone's brain that they want to become neurosurgeons, but really, so you are not following someone's examples, you are not following someone's advices. You have to love what you will decide. You are students, and I totally agree that you are finding in which directions you are going, but the most important thing is that you have to love what you will choose. No one will choose instead of you and in the place of you. You have to love the brain, the spine. You have to find yourself in those branches. No one, not me, not Dr. Tornike, will give you some advices, but the primary is that you have to love your job. It doesn't matter if it will be neurosurgery, spine surgery, endovascular surgery, or any type of surgery or conservative direction of medicine. You have to love what you are doing, and not us, but someone very clever than us say that if you will love what you're doing, you will never work in your life. It's true that if you love your job, what you're doing, you are not considering that you are going to work. It's the same like with us as well. We're not saying that we are going to our working place because we are family, because every new patients are the member of our family, and this is what we are choosing the medicine. And doesn't matter you will choose neurosurgery or I don't know, the orthopedic surgery. You have to love your direction, what you will choose. This is our aim. It's not mandatory that everyone will choose neurosurgery. You have to choose your comfortable zone. In which zone you will feel comfortable. It might be conservative directions of neurosurgery, I mean therapy, or in surgery. Doesn't matter, but feel free to be comfortable in the field what you will choose.
Thank you so much, sir. That was very inspiring.
Thank you so much, Dr. Koka, Dr. Tornike. Thank you so much for all the insights throughout. I believe I'm speaking on behalf of all the participants that they were totally intrigued by throughout the presentation. And I would also like to introduce participants to the concept of IASSS. So IASSS is the International Association of Student Surgical Societies. Currently, the purpose of IASSS is simple. We are here to empower all these students. So I think most of us, 50% of us here would be interested in becoming surgeons, either neurosurgeons or any other surgeons. So future surgical leaders, and fostering a community and providing a platform as educational resources and creating opportunities and professional development for all the medical students worldwide. And it is also a good opportunity to network and register. We also have international workshops. We have our patrons at IASSS, that is Professor Ken Boffard. He is the Secretary General of International Surgical Society. And the main aim of International Association of Surgical Societies is to create a platform where all surgical enthusiasts can learn what are the skills that you need to develop to excel in the field of surgery. So answering the question, many questions, students have this question, we want to become a neurosurgeon. So how do we learn the skills? How do we network? How do we create international opportunities, global networks with partners? So IASSS acts as a platform where you can connect with students from multiple countries. You can learn from doctors from different countries. I believe today also we have some students who are not from Georgia. They are joining us internationally from Europe and from India. And they are also learning from neurosurgeons in Tbilisi. Similarly, we can have a chance to learn from neurosurgeons from Europe, from South Africa, from Australia. So that's the opportunity we have. IASSS also sponsors student surgical societies. It encourages them to create student surgical societies in countries where there are no surgical societies or there's no concept. So currently we have 203 active member societies. Also, we have 107 active countries and 745 universities with IASSS. And this is the membership demographics. We also are having International Surgical Week in 2024 in Kuala Lumpur, Malaysia. And you can have a chance to go there. You can connect with people in Malaysia. You can become members with IASSS. These are the current surgical programs that were run in 2023, Introduction to Surgical Skills, Basics of Colorectal Surgery, and how young researchers can excel in the field of surgery. I think Dr. Koka and Tornike will agree that how important it is to be involved in research also, even if you are in the field of surgery. So I would share the details how to get involved with IASSS, our social media accounts, and I would also invite Aditi from GIMSOC to share about GIMSOC, information about GIMSOC.
Hello, everyone. So GIMSOC is the Georgian International Medical Student Society here at Georgia, and our main goal is to build a society, a community where medical students get the opportunity to refine their skills and knowledge. And our main goal is to provide these opportunities to medical students through various events and workshops, conferences, and we have a lot of them planned for the upcoming months. We had a crazy month of April with a lot of events, and we're ending the month of April today. But feel free to sign up for events that are open to everyone. So as of now, the most of the events are restricted to the members, and the membership forms will open soon. So I'm looking forward to having you all as a part of the GIMSOC family. And I would also like to thank Dr. Koka and Dr. Tornike, as well as the IASSS, the National Delegate of Georgia, Dr. Rajika Singh Tak. Thank you so much for the collaboration. Thank you so much for the knowledge. It has truly been a very informative and intuitive webinar. So thank you so much. And thank you so much, everyone, for attending and joining. And thank you.
Thank you so much from the end of IESSS to all the attendees. And once again, thank you so much to Dr. Tornike and Dr. Koka.
Mm-hmm.
Thank you.
Thank you.
It was very nice. With you, Aditi, Rajika, thanks. You were excellent.
Thank you, guys. It was
Thanks.
great.
Bye.